So it takes us over an hour every time we talk to a patient about smoldering myeloma. It's very critical because you're asymptomatic. You're deciding whether I want to take the risk of treatment now, or I'm going to wait and keep watching every 3 months, every 6 months until something falls apart. I think in general, I think of it as this way. In other cancers, we never wait for patients who have end organ damage. We never tell them, wait until you have metastasis, fractures in your bones, kidney failure, and then I treat you. So by definition, the CRAB criteria was developed in the older days when we didn't have good treatment. Let's rethink about it, because any other cancer in the world, we never wait for them to have a lot of disease and then we treat them. So CRAB is actually crabby, and it should not be used, or crappy. Then the second question is, now can I define who should be treated? Because some patients will never need treatment in their lifetime, and that's very critical. So if we improve our risk stratification, then we can truly define someone who will progress in 2 years, someone who will progress in 5 years. And by giving that choice to the patient, you can then ask them, do you want to be treated now, or your risk of progression will be higher? And again, we don't treat outside of clinical trials. We offer very close observation or a clinical trial to see if that can improve. Then the third question is, what kind of clinical trial am I using? And we have lots of options because it's good to have choices for your patients. Some patients may use something less intense, especially if they're older or frail or don't want to have a therapy that's very intense. Some patients who are younger or want something that's very intense can choose that. And just like in myeloma, we have lots of options of treatment. You want to give options to your smoldering patients. I really believe in immunotherapy because I think that's when your T cells are in their best shape before you overuse them in multiple therapies before, and then you use it in the 5th or 6th or 7th line of therapy. And I think the T cells work best when you have less tumor burden and when you have an immune system that's functional and when you have less genomic complexity. So by definition, bringing our bispecifics and our CAR T and our other therapies as early as possible will make a huge difference. And indeed, we're seeing that. We presented early data. We're hoping to present more data very soon about how effective the immunotherapeutics are in smoldering myeloma, and they are safe. I think that's a critical point. When people hear about bispecifics or CAR T, they're so scared of the side effects. Remember, side effects are usually when you're trying to give something that activates the immune system in very heavily pretreated patients. So you get, of course, all of the toxicity. Now you avoid a lot of the toxicity and you potentially get a much higher benefit from those therapies. And maybe that will be the answer for all of this controversy in smoldering myeloma.